Oh, I'm sorry. Are you hearing me now?
Yes,
Okay,
doctor.
sorry. All right, so start back again. The ophthalmic history, right? Always listen to the patient. They might be telling you the diagnosis, as you well know, right? The history is a very important part of diagnosing and determining what investigations you'd like to do and the treatment. So just to have a little discussion before we start, a 56-year-old female presents to her GP complaining, "I can't see, doc." What questions would you ask when taking the history? Let me see who is here. I see Gordon. Okay, so you'd like to know the duration? Mm-hmm. Anything else? You have to find out about chronic illnesses. That's correct. But before then, how about right? Which eye? Is it both eyes? Is it a monocular loss of vision? Is it binocular? Is it bilateral? Is it sudden, painful, painless? Very good. So you have I see you've been doing a little bit of reading. So because all of those questions will give you some idea as to a possible diagnosis. Okay, so let's go to the next. So in history taken in ophthalmology, as we all know, obtaining an accurate history is the critical first step in determining the etiology of the patient's problem. It is estimated that up to 80% of diagnoses are based on history taking alone. It helps focus your examination and indicates when and what investigations are required. So, as I think you all know, there are some basic things which are required, which you also do in any history taking. Okay, and that is, of course, you need to know the patient's demographics. Very good. Very important. You have to name, age, gender, occupation. Okay. Their presenting complaint, history of the presenting complaint, past ophthalmic history, past medical history, and the other things which are you also do in any medical history taking, the drug history analysis, social and family history, and systemic review. So let's start with the history of the presenting complaint. So that you basically have to ascertain the main reason the patient decided to seek an ophthalmic consultation. And I'm sure, as you've been taught, always start with an open question. What brings you here? How can I help you? What seems to be the problem? Is there a problem with your vision? Is there a problem with your eyes? So you always start with an open question. Let the patient describe the problem in their own words. And also you should record what the patient's, it should be recorded in the patient's own words. Other things that you have to ask about is the duration, as someone mentioned. How long have you had these symptoms? Is it unilateral or bilateral? Is it affecting your right eye or your left eye, or is it both eyes? Is the loss of vision or blurred vision, is it central or is it peripheral? Are there any associated symptoms? Have you had any similar problems before? Okay. Now, some of the most frequently encountered complaints in ophthalmology, of course, would be blurred vision or loss of vision, double vision, a red eye discharge, eye pain, eye ache, headaches, photophobia, halos, flashing lights, and floaters. Okay, and we're going to deal with these complaints one by one. Okay, so the frequent presenting complaint is, "I cannot see," or they may say, "My vision is blurred," foggy vision. Okay, now you have to determine when they present a visual disturbance. First thing you have to know is when did it start? You need to get a history of the onset and also the severity of the visual disturbance. Is it just mild blurring? Is it total loss of vision? Severity of the visual loss is frequently a predictor of the prognosis. So if a patient comes in and they can't see anything at all, they have total loss of vision, which is not transient but sustained, then the prognosis then is very poor, because you're thinking the patient has probably had some vascular or circulatory problem, retinal vein occlusion, and arterial occlusion. Okay? Then, as we mentioned before, which eye? Is it the right, the left, or both? Meaning bilateral. Another question that you have to ask is the blurred vision for near or for far? Okay, I see a name popping up here, Dale. Dale, if a patient tells you that they have blurred vision for the distance, but they can see clearly close up, what would be your initial thought? What would be your initial diagnosis? Hello? And
Kind of, can you repeat that, please?
if a patient presents to you and tells you that they have blurred vision near, but they can see clearly in the distance, what do you think is happening there?
Are they faster?
They're farsighted, correct. And so patient, so that's the first thing you're thinking. That's unless they don't have any other complaints, right? If they're not hypertensive or diabetic. But if a young person comes in and tells you, I can see clearly in the distance, but I can't see things sort of close up, or have blurred vision, say at my computer, then you're thinking that the patient may be hyperopic. If the patient tells you, I can see clearly things close, but I have blurred distance vision, then obviously you're thinking this patient, oh, could this patient be nearsighted or a myope? Okay? If you have someone who, so correct, myopia. And if you have anybody knows what presbyopia is? Have you ever heard of that term? No? Okay. So presbyopia is difficulty with close work, but it's different from farsightedness. It is usually happens after 40. So if I don't know if you noticed, most of you might have your parents might be in their 40s or 50s, and they can't read their fine print, and they have to reach for their glasses to see their fine prints. I don't know if that's familiar to you, right? I don't know how old your parents are in general, but usually it's called presbyopia, and it's loss of accommodation with age. Usually starts around 40, where you have difficulty seeing your close work, fine prints. And that's why you see patients buying, over 40s, buying reading glasses. You can get over-the-counter reading glasses. Okay, so it's very important to find out, is a visual disturbance, is it worse for near? Is it worse for distance? Are you having problems reading your fine prints? Okay, and also an important thing to find out, is a blurred vision in the center? Is just central scotoma? If the blurred vision is just in the center, then you're thinking of macular disease or optic nerve disease. If the visual loss in the periphery, right? So if they have peripheral vision loss, they can't see things to the left or the right until the object is almost right into the center of their vision, then you're thinking more of something like glaucoma or retinitis pigmentosa. Another question that you have to ask, is the visual loss transient? Does it last? How long does it last? Does it last for a few seconds, a few minutes, or is it sustained, or is it persistent or permanent? So you have to ask about the duration of the visual loss. Transient visual loss, if the patient tells you, I lose vision for a second or two, and then it comes back, then you're thinking of something completely different, as opposed to someone who tells you, I have blurred vision and it's always blurred. So if the case is it's transient loss of vision, you're thinking of things like amaurosis fugax. I don't know if you know what that is, That's the equivalent of a transient ischemic attack. Papilledema, giant cell arteritis, migraines, those are all causes of a transient visual loss. But a sustained visual loss, you'd have to think of other things like a cataract, or if they're having some retinal disease. Another thing to elicit from the history is the visual loss sudden or gradual. If it's sudden visual loss, as I said before, you're thinking of something, probably it's vascular, like a central retinal artery occlusion, central retinal vein occlusion, giant cell arteritis. However, if it's a gradual, painless loss of vision, then you're thinking of cataracts, glaucoma, diabetic retinopathy. So is it painful or painless? If it's painful, then it's usually something in the anterior segment of the eye. Do you know where the anterior segment of the eye is? Anybody? What do we consider to be the anterior segment of the eye? No responses. Okay, vitreous humor? No, the vitreous humor posterior segment. So it's the front of the eye, right? So what are the structures that are the front of the eye? What we use to define the anterior and the posterior segment is the lens. So anything, the lens and anterior to the lens is the anterior segment. So your eyelids, conjunctiva, correct. Cornea, iris, very good. And anything behind your lens, your vitreous humor, retina, choroid, optic nerve is your posterior segment. All right. So you'll find that most anterior segment disease, or not most, but usually if it's painful, it's usually anterior segment. There are very few posterior segment diseases that present with pain, unless it's something like an optic neuritis, where you can get pain with eye movement. But in general, painful eye problems are usually anterior segment. Another presenting complaint, of course, which you would have known about, is diplopia. And what you have to decide, it's very important to elicit from the patient, is the double vision monocular, meaning if they cover one eye, say they cover their left eye and they're still having double vision, then you know it's monocular. However, if it's a binocular double vision or binocular diplopia, if they one eye, the double vision disappears. Okay? And the causes of monocular diplopia are corneal disease or a cataract, as opposed to binocular diplopia, which usually tells you that there's more than likely some sort of cranial nerve palsy or strabismus, such as thyroid eye disease, fractures of the floor of the orbit, diabetes, myasthenia gravis. Okay? So double vision is a frequent presenting complaint, but you also have to find out, is the diplopia present with one eye, or is it only present with both eyes open? Halos are also a frequent presenting complaint. Halos usually occur when you have corneal edema, such as acute angle closure glaucoma. You can also get some sort of halos too with cataracts and, say, oncoming lights at night, say, for night driving. Photopsia, have you ever heard of photopsia? Do you know what photopsia is? No. It's basically what we call a flash of light. Patients will frequently describe flashes of or streaks of white lightning at the side of their vision. And we see that mainly, we can see it in migraines, but we also, when we get patients who complain of photopsia, we have to examine the posterior segment, because it can be a sign of a retinal tear or a retinal detachment. Also floaters, and photopsia and floaters often go hand in hand. So patients often come in, I'm seeing lights flashing, and I'm seeing spots in front of the eyes. And we get spots in front of the eyes in conditions like a vitreous hemorrhage, a retinal tear, retinal detachment. So when a patient comes in with a flashing light and floaters, then we know that what we have to do, we have to dilate the pupil because we have to examine the patient's retina. So it's very important to elicit symptoms like those. Do you have photopsia? Do you have flashing lights? Do you have floaters? Do you have spots or in front of your eyes? Another presenting complaint is distorted vision, also called metamorphopsia. And when patients, meaning the vision, the images that the patient is seeing, usually like lines are wavy. They complain that the lines are wavy, they're not straight, or patients' objects look distorted, and that's usually a sign of macular disease. So here again, we'll have to dilate the pupil and ensure that we look at the back of the eye. You also have to ask about color vision abnormalities, night blindness. It's also called nyctalopia. And night blindness, one of the commoner conditions causing night blindness would be retinitis pigmentosa. And of course, another presenting complaint is oscillopsia, or shaking of images. Does anybody have any idea what condition would give you oscillopsia? Mr. Mirali, do you know what condition gives you oscillopsia? Anybody? Miss Gordon?
No, Doc, I'm actually not sure.
You don't know. Anybody? Nystagmus. Very good. Excellent, Miss Rose. So yes, so a patient who complains that their images are shaking quite frequently, they have nystagmus. Okay, another frequent presenting complaint is redness. Very common. Patients come in complaining, I have my eye is red, doc. Usually, yes, Miss Pedlar? Miss Pedlar?
Good morning, Doc. Sorry to interrupt. I was wondering if it would be the same, the oscillopsia,
Mm-hmm.
if it is somewhat equated to the patient complaining of like seeing images spinning around them.
Spinning is slightly different. No, it's not usually spinning. Spinning, you mean like that's usually spinning is usually more in the air problems, isn't it? Or when you say that, you're looking at images and the images are shaking, as opposed to you're feeling that you're spinning. Is that what is that what you're asking?
The room spinning.
No, it's not. They wouldn't say it's spinning. They're looking at something. They're looking at an object, and the object seems to be moving, shaking.
Thank you.
Okay, so it's not. It wouldn't be spinning. Spinning. No, the object wouldn't be rotating. It would be shaking, more like a back and forth kind of thing. So redness, a red eye, is a very common ophthalmic presentation. Usually suggests a disorder of the anterior segment, right? And of course, as I said, the anterior segment includes your conjunctiva, keratitis, your cornea, scleritis, scleroiritis. It's the iris and uveal tissue. Another frequent complaint is ocular pain or discomfort. And you have to find out the severity and the nature of the pain, because that will give you a clue. Is that aching or a boring pain? Is it a pain that is with eye movement? Is the pain worse with lights? Patients will often say my eye is painful, and when I go out in the sun, the pain is that much worse. Okay, so pain with eye movement, then you're going to start thinking of an optic neuritis. If they're having an aching or boring pain, they start to think of things like a scleritis. Photophobia is quite frequently associated with an iritis or anterior uveitis and corneal abrasions. Do they have an accompanying headache is also important. You can get that with many conditions, okay, like giant cell arteritis, iritis, scleritis. And do they have any burning, dryness, or itching? If there's an associated headache, of course, you're going to think of things like a migraine, temporal arteritis, benign intracranial hypertension. And the other presenting complaints you have to ask about are any abnormal secretions. Do they have a watery eye? And that's called epiphora. Right? So the patient complains of a constantly watering eye. Does anybody have any ideas what you could be thinking of if they're complaining of a watery eye? What could be the problem? What conditions give you a watery eye that you can think of? Allergies, very good. Allergies, yes. Anything else? Foreign body, corneal foreign body, trauma, yes. Okay, so anything that's an irritant to the eye. So if the patient gets, you have to ask them, did anything blow in their eye, get into their eye, any history of a foreign body, any history of allergies? That is correct. Also, other reasons for epiphora or watery eye would be a blocked lacrimal duct, correct. Tear duct obstruction, correct. Okay, so you have to ask about if there's a watery eye, or if they present with a watery eye, then it gives you some idea of what you're going to be looking for. So when you're going to look at the eye, you make sure you invert the eyelids, you examine the eye properly, looking for any foreign body objects, looking for signs of allergy, okay? And also a discharge. Quite frequently patients come in with a discharge, right? So they have this, they tell you that their eyes sticky or their eyes stuck together in the mornings. And you have to make sure you find out what kind of discharge is this. Is it a purulent discharge? Is it a mucoid discharge? Is it a watery discharge? Right? So if it's a purulent or a mucopurulent discharge, what are you thinking of? What could it be? Correct, an infection. So if it's a purulent or a mucopurulent, then you're thinking the patient must have some sort of infection, as opposed to a mucoid or watery, and you're thinking of allergies, foreign bodies, other things. So not only do you have to ask about a discharge, but you also need to know about the nature of the discharge. What kind of discharge is it? Okay, so that was different features of the presenting complaint. The commonly, the common presenting complaints in ophthalmology, right? So the main things that you have to think about: loss of vision, onset, duration. Is it transient? Is it permanent? Is it intermittent? Okay. Is it painful? Is it painless? And any other accompanying symptoms. Do you have pain with eye movement? Is the eye red? Is there epiphora? Do they have discharge? Okay, but to try and get a picture of what could possibly be going on. Of course, you have to ask about their past ophthalmic history. Okay. You have to ask about previous eye problems. There's certain eye problems that are recurrent, such as herpes simplex keratitis, iritis, uveitis. Okay, so you need to ask about previous eye problems. You need to ask about ocular history. Have they had any recent ocular history? Ocular surgery, sorry, such as a cataract operation or any operation at all. Okay, You have to ask about ocular trauma. There are certain conditions which are associated with ocular trauma. So a patient may have had a blunt trauma to their eye 10, 20 years ago and present with angle recession glaucoma. So it's very, 10, 15, 20 years later. So it's very important to elicit any history of significant ocular trauma in the past. You also have to ask them if they have any known refractive errors. Are they nearsighted, myopic, or are they farsighted, hyperopic? Histories of a squint. Did you have a cast eye as a child when you were growing up? Did you have surgery for a squint? Okay, because if they have a squint, quite often people with squints, one eye may be what is called a lazy or amblyopic eye. You might have touched on that yesterday with Dr. Crossman in strabismus. It's also very important to find out, depending on the presenting complaint, are the contact lens wearer. So a patient who comes in with a red, painful eye with a discharge, you have to make sure that, find out, do you wear contact lenses? Okay, so in the past ophthalmic history, very important to find out your previous eye problems, because is this a recurrent problem? Have you had any ocular surgery? Okay, because if you've had ocular surgery, you can present with an inflamed eye several months and years post-op. Have you had a past history of ocular trauma? Do you have any refractive errors? Do you have a squint? Did you have a squint or a lazy eye? Are you a contact lens wearer? Oh, those are all important questions to ask in the past ophthalmic history. In the past medical history, as I'm sure you will find the things that affect the eyes, in particular, diabetes, very important. Diabetic retinopathy is one of the leading causes of blindness in Jamaica and in the world. Okay, so you have to find out about diabetes. Are they diabetic? Is it type 1? Is it type 2? Duration of the diabetes and their glycemic control. Of course, hypertension. Hypertension is implicated in many ocular problems, such as apart from hypertensive retinopathy, retinal vein and arterial occlusions are associated with uncontrolled hypertension. Atherosclerosis, ischemic heart disease, also associated with ocular problems, especially vascular problems, such as vein occlusions, arterial occlusions. Autoimmune diseases is very important to ask about, depending on the presenting complaint, because of course there are certain autoimmune diseases which are associated with eye problems. So patients with SLE and rheumatoid arthritis, Sjogren's syndrome, they get uveitis, posterior anterior uveitis, they get a scleritis. So depending on what the presenting complaint is, it's very important to elicit from the patient if they have a history of any autoimmune diseases. Patients with rheumatoid and arthritis and SLE also frequently present with a dry eye. Okay, they come in with a dry eye, intermittent blurred vision. They can have a scleritis, uveitis. They also have problems with their posterior segment. Okay, cancers, yes, it's important to ensure that you ask about cancers, because you can have primary and secondary cancers, right? There are cancers, particularly colon and breast, which metastasize to the eye, and you get choroidal metastases. So it's very important to ask about cancers. And also asthma. We tend to ask about asthma too, because a lot of the treatments that we give, say for glaucoma, the glaucoma drops quite frequently have a beta blocker, and that would be contraindicated if the patient is asthmatic. Okay, so these are some of the important things that you have to elicit in the past medical history, right? Of course, drug history and known allergies is also important. Many drugs have adverse visual or ocular effects, okay? So steroids are implicated in cataracts, and also steroids can also cause raised intraocular pressure, and that, as you know, may lead to glaucoma. All right, so you have to ask the patient if they're on any form of oral systemic steroids. Antidepressants and antipsychotics may cause pupillary dilatation and may induce pupillary glaucoma. Antidepressants and antipsychotics also cause dry eyes. Okay, so you have to ask about if they're on antidepressants or antipsychotics. I think most of you would know that hydroxychloroquine causes retinal toxicity. What conditions do you use hydroxychloroquine in?
You can use it
Malaria.
in malaria,
Yeah,
autoimmune.
SLE, right. So in Jamaican situation, we don't see that much malaria, but it's very commonly
Autoimmune diseases. Well,
autoimmune diseases, correct. SLE and rheumatoid arthritis too. Okay.
rheumatoid.
Yes. So it's very important because, of course, you know, these patients can develop what's known as bullseye maculopathy. So you have to make sure if a patient who tells you that they have SLE or rheumatoid, make sure you find out, are they on hydroxychloroquine? Of course, anticoagulants, you can get bleeding in the eye, right? So they may present with a subconjunctival hemorrhage, a hyphema, retinal hemorrhages. So it's very important to find out, are they on anticoagulants or any kind of blood thinners? Obviously, you have to find out what eye medications they're taking. Are they on any steroids or antibiotics? Are they taking drops for glaucoma? Very important. Patients often don't, what should I say? They don't offer this information. You have to actually ask them. And of course, you have to ask about drug allergies. In particular, self-allergies for ophthalmology, because in ophthalmology, we tend to use, particularly in glaucoma, we use carbonic anhydrase inhibitors for glaucoma, and those patients with sulfur allergies obviously can't use that. So there are certain things, of course, you'd ask about the regular drug allergies, to antibiotics, whatever, to any drug allergy. But particularly, you have to ask about sulfur allergies in particular. Okay. Family history. So we always have to ask, has anyone in your family had any eye disease, or have they ever gone blind? Quite frequently, patients might not actually know what the family member might have, but they're able to tell you, well, my grandmother, my grandfather went blind, and that's particularly important, say, in our setting with glaucoma. Glaucoma is probably the second leading cause, if not the first leading cause of blindness in Jamaica. And quite frequently you have a family history of glaucoma. But patients might not be able to tell you, my grandmother had glaucoma. What they usually tell you is that my grandmother went blind, and my aunt is blind, and I have a cousin who is blind. Okay? So you try to elicit any family history of eye disease or blindness, because that will sometimes determine how you manage a patient. If I see a patient with say, raised intraocular pressures, and they have a history of blindness in their family, I might want to be more aggressive in my treatment, as opposed to a patient with raised intraocular pressure who has no family history of glaucoma, no history of blindness. Then I might not feel that I have to be as aggressive in my management of this patient. Okay, and you also have to elicit a history of, is there a squint? Quite often squints there's a familial history. Glaucoma, as I mentioned before, very important in our setting. Sickle cell disease, very important. Is there a history of refractive errors? Quite often I see children, they're nearsighted. If you ask their parents, the parents are also nearsighted. So there tends to be a familial component to certain refractive errors, in particular myopia and astigmatism. Also congenital cataracts. You know, you have to ask, did anyone in your parents have cataracts from an early age? What age did they have cataract surgery? That kind of thing. And of course, the social and family history is the same as with any history taking. You can ask about smoking, alcohol, occupation, very important in ophthalmology, especially as it comes to trauma. We see a lot of trauma, gardeners, people working in industrial sites, carpenters, people hammering nails, ending up with intraocular foreign bodies. So occupation is very important. In our setting, also well, I wouldn't say in our setting, generally speaking, you have to ask about computer use, screen time. That is increasingly becoming a problem. Patients who have spending too much time in front of their screens, whether laptop, tablet, phone, ending up with a lot of problems, getting eye strain, dry eyes, computer vision syndrome. So occupation is very important. Screen time, very important. Okay, smoking and alcohol, as you can well imagine, will affect diseases of the eye, especially vascular diseases. So if you have a smoker who's hypertensive and diabetic presenting with sudden visual loss, then you're going to think it's something vascular, a retinal vein occlusion, retinal arterial occlusion. Okay, alcohol has certain effects on the eyes. It can affect the optic nerve. You can get an optic neuropathy with excessive alcohol use. And if alcohol and tobacco, so you can get an alcohol tobacco neuropathy. They present with optic atrophy and poor vision. Right, but those are questions you would have asked anyway, but it's important to remember to ask about the social history. Okay, so that's basically it in the ophthalmic history. Is there anything else, anything you'd like to ask me? Any questions? Everybody's asleep already. It's early in the morning. Docs, what's you've asking floaters? Are floaters a serious pathology? Okay, so floaters within themselves are not serious. They are more irritating and annoying. However, and in the vast majority of patients, floaters are benign. However, in a very small percentage of patients, they may be a sign of a tear in the retina or a retinal detachment or a vitreous hemorrhage. And those are serious eye problems, eye diseases. So whenever you have a patient who complains of floaters, then you have to dilate the pupil so as to exclude any sight-threatening eye disease. So the floaters in themselves are not serious. They're more an annoyance, okay? But in a very small percentage of patients, they can indicate that you might have a tear in your retina, a retinal detachment, or a vitreous hemorrhage. So it means that you have to or should dilate the patient. Okay, so just exercise really to go through, give you an idea of how the narrative for an ophthalmic history would go. So you have a patient, and remember now you have to introduce yourself, right? And you ask a simple question, an open question. What brings you to see me today? Patient will say, I can't see. Then you have to find out, is it one eye or both eyes? Are you having trouble with one eye or both eyes? The patient will tell you whether it's the right or the left, and then they usually will elaborate. I can't read my Bible and the faces on the TV are blurred. And then you'll have to ask, when did you first notice the problem? So you want to have an idea of the timing, onset. and the duration. And then you ask, did you lose vision gradually or suddenly? Because you would like to know. That's very important. It helps you to, in the diagnosis. Patient says gradually. Has the vision worsened, improved, or remained unchanged? I think it's getting worse. Okay? If it's improved, then it's not likely to be there are certain diseases which resolve spontaneously. So if the vision has improved, I'm thinking it's either something superficial, like the corneal surface, a dry eye. It could be a uveitis, and a mild anterior iritis sometimes resolves spontaneously. Okay? Is it getting worse? Is the patient worse when you're reading or when you're looking at the distance or both? So that will help you to determine, give you an idea. Could this be a myopia? Could this be a hyperopia? Could this be presbyopia? Is there an associated pain or photophobia? The patient says, no, I have to stop driving at nights because of the glare from oncoming headlights. Are you seeing any flashes of light or seeing spots? Patient says, no. Have you had any previous eye trauma or eye surgery? Yes. I got hit in this eye with a cricket ball several years ago, and I had cataract surgery in my left eye 3 years ago. Are you taking any medications for any other illnesses? Yes, doc, I take medications for hypertension, diabetes, and I used to be on prednisone for arthritis. So right away, I have an idea of what's wrong with this gentleman. Do any of you, any thoughts? Remember now, the 66-year-old patient appears to be diabetic hypertensive, has taken steroids in the past, has gradual loss of vision, gradual painless loss of vision, having halos. Yes, excellent. Cataract. Okay, so just from, and they've had cataract surgery in the other eye, right? So just from the age of the patient, the patient is 66 years of age. Okay, from their past medical, from their history, this is gradual painless loss of vision. Okay, they're not having, it's painless, so no photophobia. They do have a bit of glare, which you expect, right? They're not having any flashing lights or floaters. So then right there and then I say to myself, gradual painless loss of vision, no flashing lights or floaters, so it's not likely to be the retina. The patient is diabetic. So of course you'd have to think of retina, because you'd have to think, are they having diabetic retinopathy or, you know, a maculopathy? But they're not having any flashing lights or floaters, and they've had a previous eye surgery. So the past ophthalmic history also clues me in. If they've had one cataract done in one eye, then it's quite likely that they have a cataract in the other eye. Cataracts tend to be bilateral. And they're on certain medications. I see that the patient is on prednisone, and that again clues me in. Patient is on prednisone for arthritis. What does prednisone do to the eye? Prednisone causes cataracts. Okay, so just from the history alone, I already have an idea what this patient has. Okay, so history taking, there's an aspect to it, but if you do it systematically, you know, before you even examine the patient, you already have an idea what's wrong with the patient. Okay, so just to conclude this, so this is the patient, right? And that's a cataract. They have this white opacity in the center there of their pupil. The pupil is dilated, what we call a leukocoria. There is no red reflex. And the patient here, okay, so the patient, this is a cataract there, and then post-op, you can see that the patient had the cataract removed. You now have a red reflex, which is what we normally see, which is a reflection of the retinal circulation, and the patient has had an intraocular lens implanted in the eye. They had cataract surgery with intraocular lens implant. Okay, so the history is very, very important. And I said, before you even examine the patient, your history will give you an idea of what you need to focus on. what you need to look for, what could possibly be the diagnosis. Okay, so that was your lecture today. So this is this is probably going to be your shortest lecture. Any questions? Any questions about the ophthalmic history? Yes, is it Miss Gordon?
Yes, Doc. I wanted to ask you, sometimes when you do the past medical history and the past what is it, the past ophthalmic history, they
Ophthalmic
both
history?
a past ophthalmic history, they both kind of coincide. So is it that you have to do them separately, or you kind of just do them?
No, man, you do them separately. They don't really coincide. The past ophthalmic history asking specifically about problems with the eye itself. So you have to get very
Okay.
specific. Hmm? Have
Okay.
you had previous eye problems? Have you
Right.
had ocular surgery? Have you had ocular trauma? Do you have a
Okay.
refractive error? Of course, you're not going to say refractive error. You're going to ask them, are they nearsighted? Are they farsighted? Do you wear glasses? Is that what you probably will ask? Okay, so when you're asking about refractive errors, you will say to the patient, do you wear glasses? What do you wear glasses for? Do you wear glasses to see in the distance, or do you wear glasses to see things close up? Okay, so the
Okay.
history is very specific, okay, to the
Okay.
eye.
Okay.
Okay, as opposed to the past medical history, which is general, which is the sort of questions you would ask in any history. Are you hypertensive? Are you diabetic? Any pre-existing systemic conditions, basically.
Okay.
Okay, all
All right.
right.
Thank you.
Mm-hmm. Any other questions? Okay, well, that is it for your morning lecture today. Okay, so I'll see you next week. I'm not sure I have any, just to review practice, correct? Unfortunately, you're not in the settings, because if you're at the clinic, you would be doing this. You'd be, you'd be asked to take a patient and ask a history. But unfortunately, that's not the case, which is, your loss. This is the best we can do. Okay, then?
We
All right,
can
then.
practice
Good
on our
day.
parents, Doc.
Mhm. You
We
can,
can
that's
practice.
very true. You're quite right. Practice on your parents.
Mm-hmm.
All right. Bye-bye.
Bye bye, Doc. Have a good day.
Same to you. Same to you.
All right. Bye bye.